All right, so let's talk about some respiratory emergencies. First of all, foreign body aspiration. Something is aspirated into the airway and it either partially or completely obstructs the airway. If it's a large airway that is completely obstructed or partially obstructed, that's an emergency. Smaller airways will still allow for adequate air movement and gas exchange, but can become a focus for infection. Some items, if aspirated, may degrade and release harmful chemicals. Think about those button batteries and things. So an aspiration may actually be asymptomatic, especially if a small airway is affected, until they develop secondary symptoms, which would be signs of pneumonia. A large airway obstruction, they may be gasping, they may have stridor, they may have cyanosis, they may have a paroxysmal cough. They just keep coughing and coughing and can't stop. Their body's trying to cough that up. They may have asymmetric breath sounds if it gets into one of the main stem bronchi. If the larynx is obstructed, they will not be able to speak or breathe. So usually large airway obstruction is fairly dramatic. Small airway obstruction, we may not see that until they develop pneumonia. Medical management, you have learned emergency management of a large airway obstruction. Smaller airways or for a partial obstruction, that may need to be removed with a bronchoscope. Nursing care, again, you've learned emergency management of airway obstruction, and we need lots and lots of teaching about prevention. So we teach families what objects are high risk for aspiration, thinking about small kids. So small hard food chunks like carrot, things like that. Thick sticky foods like peanut butter, small toys and objects, burst balloons, plastic wrap, those plastic bags from the store have gotten thinner and thinner, button or disc batteries. So think about things that are small enough to go in a child's airway. Okay, next we want to talk about pulmonary edema and what happens. Increased pulmonary capillary pressure causes fluid to leak out of those capillaries. So the alveoli have fluid in them. So this patient may have fluid overload, they may have hypertension, they may have kidney disease or heart failure, okay? But what's causing is the fluid. The capillaries are over distended with fluid, and the fluid is moving out into the airways. Now, this can also happen because of increased pulmonary capillary permeability. So this is when we have something like an acute lung injury or ARDS. The capillaries are injured, and so they get leaky. This can happen, and sometimes we might have both, but think about, we've got too much fluid in the capillaries, so it leaks out, or the capillaries get leaky, and so the fluid leaks out. So that can be ARDS, acute lung injury, and some other potential causes. So fluid moves from the pulmonary vessels into the alveoli and the interstitial space of the lungs. The alveoli are filled with fluid rather than air, and so it interferes with gas exchange. What does this look like? Well, this patient becomes short of breath. They may be cyanotic if they're hypoxic enough. They're tachypneic because they have less space, so they have to breathe more to get enough air. They may have diminished breath sounds and then develop crackles. They may have anxiety, agitation, confusion. They may be diaphoretic and sweaty. They may have orthopnea. When they lay down, they can't breathe. When they sit up, it helps, because think about, you've got water in part of your lung tissue. If you're laying on your back, then all of the water's covering all the alveoli on the back surface of the lung. If you sit up, that water drains down, and so it's filling the alveoli on the bottom part of the lung, and it leaves more surface area for gas exchange. In young infants, you may hear expiratory wheezing. You might hear a heart murmur or gallop if they have fluid overload. The extremities might be cool if they have some swelling. You may see jugular vein distension. If they have fluid overload, they may have a cough. If it's severe, they may be coughing up pink frothy sputum, and they will be tachycardic. Medical management is to correct the cause if possible. They need oxygen. to maintain O2 sats. PEEP and CPAP can push some of that fluid out and so that it can be absorbed, so that they have more alveolar space for gas exchange. If they're in respiratory failure, they may be intubated and ventilated, and sometimes morphine can relieve the extreme dyspnea. We have to be careful with morphine because of respiratory depression, but sometimes it can relieve that extreme dyspnea. Nursing care, monitoring, lots of monitoring of their respiratory status, watching for them to get worse. Intake and output, because this is usually a fluid problem. They will probably be in a high Fowler position to make them able to breathe, and that increases the risk of sacral skin breakdown, and then support for that family. Helping that patient stay calm can be really, really helpful. Okay, next we'll talk about ARDS.